Hi, everyone. Thanks for joining us on this third episode of our Step into Podiatry webinar series. I'm Tiffany Kildale, Career Development Manager for the American Podiatric Medical Association. And as always, I'm super excited you all could join us today. This webinar is being recorded and will be available on the Step into Podiatry website later. We'll make time for audience questions during the broadcast. So if you have any questions, you can submit them by typing them directly into the question box at the bottom of your attendee toolbar. Today, I'm super excited to have Dr. Jeffery Zimmerman join us. Dr. Zimmerman is a third-year podiatric resident. And if you all follow us on Instagram, which is official_APMA, you saw the question that we featured in our Instagram stories yesterday, which was true, false, podiatric residents perform surgery on the foot and ankle. We received a pretty strong response that this was true. So I'm going to toss it over to Dr. Zimmerman now. And Dr. Zimmerman, will you tell us the answer?
Hey guys, so it's great to be on. Thank you so much, Tiffany, for inviting me on to the webinar series. It's always fun for me to get in front of an audience of collegiate students or podiatry students and share my story with you guys and give you an insight into what it's going to be like to be a podiatry resident. As far as the question that we posed, it's a fairly simple one, but sometimes it's a little bit of a gray area as far as how far up we get to do surgery. So of course we do surgery in the foot, and then we also do surgery in the ankle, but there's always a gray area about where that is, and sometimes that's dependent on the state that you're in. So we can get into that a little bit later, but overall as a podiatric resident, you're going to be getting trained in forefoot and rear foot surgery, anywhere from elective cases to trauma. So without further ado, I'll give you just a brief background as far as my history. I'm originally from Pennsylvania, and I did my undergraduate studies at a small liberal arts college, Lebanon Valley College. And my story is I stumbled upon podiatry, and I'm so glad that I did my shadowing and did my hours and got into Temple. And from there, I knew I wanted to stay in a geographical area, but also be able to go do a residency that offered a lot, a lot of experience and different types of surgeries, so that when I got out into the real world into practice, I would feel comfortable seeing all the cases that would come through the door. So I ended up at Reading Hospital podiatry residency, and so grateful and thankful that I ended up there. It was my number one choice, and it's crazy how fast it's been going through these past 3 years. It's been a whirlwind experience and trying to capture every moment that I possibly can throughout this. So what we're set out to do today is kind of give you guys a virtual shadowing of what a typical day is like for a podiatry resident. So I put together this PowerPoint that I believe all you can see now. So this is where I currently practice at Reading Hospital, currently chief resident there. So we'll just jump right into it. So in general, this is a very general, typical day in a life of a podiatry resident. So we have patients that are in the hospital, and we take care of these patients on a daily basis. We perform surgery on them, whether they have infections or in traumas. But either way, we're meeting up as a team in the morning, and luckily we have a beautiful office at the hospital where 6 of us residents will meet up, and we do what's called a sign out. And this is our time to go through each patient that is on our list and review labs and notes from other services and teams that are also taking care of this patient, maybe for the same issue that we're taking care of them, or if the patient has multiple issues as to why they're in the hospital. So we go patient by patient, and this ranges from different hospitals. At our program, we tend to see anywhere from 15 to 30 on average and upwards to 40 at a time. So we're a very busy program. And as far as residencies go, there are different styles of residency. So we're lucky enough to be at one hospital. So we're seeing all patients at one hospital. So during this sign out, we're also discussing what surgeries are on for the day. And these could be done either in the hospital or they're done outside the hospital at a surgery center. And these are more for our elective cases that would be such as a bunion, hammer toes, a flat foot reconstruction, or a high arch reconstruction. So once we kind of have our day set and we come up with our plan as far as where we're going from there, we'll tend to go to the inpatient, and that's our floor work. So we're seeing patients that are either preoperative or postoperative from a surgery that was done at the hospital, or those that are in for infections, you know, a skin infection where there's a lot of redness, or a wound that appears to be infected, and we need to treat it with IV antibiotics, and we are specifically recommending different types of wound care methods for these patients. So if we do have inpatient surgery scheduled, and I will be including some radiographic and clinical pictures of some of the inpatient surgeries that we've dealt with, that specifically I've dealt with, and then also some outpatient surgeries. So some inpatient surgeries, these include the majority of amputations, or any sort of debridement of wounds that appear to be infected. A big part of our profession is diabetic limb salvage. So diabetes is an unfortunate disease to have, and it has a great effect on the body as a whole. So we think of the eyes, the kidneys, the nerves, and when we focus in on the nerves, patients have what's called neuropathy, and this is a loss of sensation to your toes, to your foot, even to your hands. This is the furthest part away from your heart and your body. So these are the things that get affected first. So as you can imagine, if you can't feel anything on the bottom of your feet, you're going to develop an ulcer, an opening in your foot, and you can get infections, and these can go all the way down to bone. Unfortunately, the biggest issue we deal with our diabetic patients is a bone infection, and I'll be able to show you some similar cases to what we normally see in an inpatient. So after these infections occur, we then have to work them up, find out how bad the infection is by getting imaging such as x-rays and MRI, and we have to determine at what level is that surgery going to be performed. So once that is taken care of, we then take them to the operating room. And we're just not doing this by ourselves. We have teams that we work with. So one thing as a podiatry resident in the setting of surgeries is we work with teams such as infectious disease or vascular surgeons, those who have paralleled us with their teachings, and they've gone on their own path through MD or DO school, and we work with them on a daily basis. And what's the beautiful thing is we're all trying to have this common goal of doing what's best for the patient, and building those relationships is so important during residency. You learn how to deal with other services. That way, when you do go out in your own setting, whether that be staying with your program or going to another location, you then have a sense of what to expect when you're working with these different services, and you build those skills. So this inpatient surgery as a resident, it's great. I'll share a story with you. I posted on my Instagram. As I prepared for this lecture, I looked back at my first surgery, and it was an inpatient surgery. It was just as a patient that I described to you, that person who had loss of sensation, had a terrible infection to the fifth toe. It was that bad that we had to take it back to the patient's midfoot. And of course, I'm very nervous for this. And, you know, last thing I want to do is hurt the patient. So I want to make sure that I'm doing everything right by that patient. So preparing for the procedure and knowing at what level I want this to be done at. And then, of course, leaning on and discussing the case with my attending. And attendings are a big part of your education at residency. Those are the docs who have gone on after residency or are now in a teaching setting, and have that discussion with the attending. And that's such great collaborative work to think about preoperatively. So once that was completed, we get into surgery, and I'm standing at the foot of the bed performing the surgery, of course, with the guidance of my attending. And it's a really profound feeling when you're finally in it, and it makes you realize how long that education was worth it, and that you're doing something good for the patient in that moment. And it just feels it's a really cool feeling to be the surgeon. I'm not gonna lie. I always wanted to do surgery, and we can you if any of you have tuned into the previous webinar series, you kind of have an idea of how the application process is and what the education entails. So now you get to take that education with you and then apply it, and it's a really good feeling to have. So this specific case we finally got done, and the attending, you know, had his remarks and pat on the back, and you feel like you did something good at the end of the day. And of course, this was a very simple procedure looking back at it, but I've learned so much from just that one procedure and then moving forward. And that's just your building blocks. So I digress, and I'll get back on track here. But outside of that inpatient surgery, we also get to do outpatient surgery. And now in my second and third year, moving into my third year and almost moving into practice now, outpatient surgery definitely is more attractive to me, because we get to help the average person who's just dealing with pain all the time. So this pain could be from a bunion, it could be from a flat foot, it could be from nerves that are just scarred down or inflamed. So there's a variety in the outpatient setting of what we get to do as a podiatrist surgically. So like I had mentioned, we work on nerves, we work on arteries, we work on muscles, we work on bones. So I'll have a few examples, some outpatient surgeries. But as you can imagine, this day is getting busier. So if we're going back to the typical day, I think it's good to learn or appreciate the time management that goes into being a resident. You wear many hats. So in this third year setting, I'm directing the junior residents into their surgeries, and I have my own surgeries. We have to worry about the schedule that goes on during the week, creating a clinic schedule, also running academics. So as you can imagine, this is, it builds every year as you go on. So in my residency, I have clinic on a weekly schedule. So clinic is physically seeing patients in the office. So for me, this happens on a Tuesday, Thursday afternoon. So we usually have a patient schedule anywhere from 20 to 25 patients in the afternoon. There's normally 3 to 6 residents. And this is such a great opportunity for you as a resident to build your clinical skills and your personable skills, to talk with the patient, work with them, make them understand what's really going on with them. And that's where the education comes in. One of my favorite parts about clinical podiatry medicine is basically getting to teach the patient what they have. I found that by spending a little extra time teaching the patient, you have better outcomes, because the patient will understand what's going on. Therefore, they will appreciate the treatment that you recommend to them and actually take it seriously. Half of the issue is just getting them to understand what they have, not just treating symptoms. So this is, of course, with the oversight of our attendings. So we always have one attending with us during clinic, and we're working closely with them. So after we have seen the patient, worked with the patient, and signed the patient out to the attending, we then get to collaborate and decide what is the best treatment for those patients. So just to give you an idea of some of the things that we see as a podiatry resident in the clinic setting, we first and foremost deal with diabetic foot care. So we deal with ulcers, wounds, infections, and even in the outpatient setting that we work on treating in the outpatient setting. But we also get to see, a lot of fun stuff like heel pain, flat feet, neurological disorders. So there are things in the clinic that you, as the resident, is determining and then implementing that plan. And it's really fun to see these patients week after week and to see it month after month and see how they're progressing. Most residencies are set up this way, not all, but we have a very unique setting that we're able to do this. The other cool thing about residency as a podiatry resident in this setting is really seeing the full circle of a surgical patient. So again, this is a podiatric medical residency and reconstructive rear foot and ankle residency. So you are labeled as a surgeon at this point, and your job is to see patients for conservative care for these ailments. But then if conservative care fails, you as a surgeon have to determine what is the best surgery to get the optimal outcome for the patient. And that's definitely multifactorial. You have to talk with your patient and determine what is the goal of that patient. What is it, does the patient want to be pain free? Does the patient want to have a better looking toe? These all are factored into what sort of surgical procedure you're picking. So over the years of your residency, and you take as much information from your education coming into residency, but you have an algorithm or you have a database, stored in your brain of a catalog going through deciding, okay, I think this is the optimal procedure for this patient, and then you discuss that with your patient. And as a resident at our residency, you see the patient, you work the patient up, you then get to schedule the procedure, you do the procedure, and then you're seeing them up and follow up. And this is a beautiful thing, to be able to see that patient full circle. That way you get ready for the real world when you truly have your own patient population. So outside of clinic, we then end with academics. So at any residency, they have requirement for academics. So what does academics include? This can be anywhere from reading journal articles for evidence-based medicine to stay up on your medicine and see what is the new thing that's out there. Is it good? Is it not good? What things have been done in the past that is not good now, or vice versa. So it's very important to always continue your education. So we tend to do a Tuesday afternoon academics, which is after our clinic. So it's a nice full day of inpatient work, surgeries, clinic, and academics. And we'll do anything from going down to the cadaver lab and working on our surgical skills, whether that be working on flaps or dissections that pertain to surgeries that we do. We also have our journal club, which is where we discuss a specific journal with articles and that is done with our attendings. And we also do something called radiology rounds, where we have our x-rays of either surgeries that we've done the week before or those that are coming up. And that gives us the opportunity to bounce ideas off of one another and really decide if that is the best procedure for the patient, or discuss what are some pearls or skills we can utilize within the procedure to get the best outcomes for that patient. And then finally, we'll talk about social life, and that's just as important as some of the other things, because a healthy doc is a good doc. And one thing that I liked about Reading is that they do care about the mental health of their physicians. So there's plenty of time off, and they have mental health workshops and things like that to make sure that you are healthy as a physician, so that you're not burnt out, because physician burnout and even student burnout and resident burnout is a real thing. So I appreciate that my program has been able to do that. So moving on, let's talk about some inpatient cases. So this is 2 cases, and just be prepared for some graphic imaging. But one terrible infection that we deal with diabetic patients is called necrotizing fasciitis. And necrotizing means death, and fasciitis is the fascial layer that's located between your skin and your muscles. And what happens is, if you have an opening in your skin and you have a specific bug that infects to that fascia, it can actually cause gas and changes and necrosing, or just emulsifying of your tissue up plane. So it's very aggressive, and you'll be able to see what I'm talking about. So this is older patient, diabetic, just looks like a simple leg, a little swollen with a little bit of redness. There's a bandage on the inside of his ankle. But once you remove that ankle, you can notice that there's a small blip on his anterior ankle. And this is where your education is very important, and you come to really key in on your clinical skills, on your clinical diagnosis, because cellulitis and necrotizing fasciitis in its early stages look very similar. Now, I was a resident on call. It was a late Sunday night, and this patient came in, was sick, but not terribly sick, and had elevated markers, but maybe not those of necrotizing fasciitis. So I'm working this leg up, and something just isn't sitting well with me, and I believe that this is necrotizing fasciitis. Now, when you use that word, people take it very seriously, and it's not heard of very often. So they may challenge you on your diagnosis. Unfortunately, this might have been, well, this was the case for this patient, but it was also working with the patient that was very troublesome with this specific case. The patient didn't appreciate what actually was going on with his leg and refused surgery initially. It was also difficult to get him to surgery for other services to agree with the diagnosis and moving on. So again, that's why it's important to know the verbiage, to know what you're talking about when you're talking to these other services. So this was the outside of his ankle the next day, and you can see that it does not look good. Just that simple redness that you see on the top middle picture is vastly different to what you're seeing on the outside of his ankle. So this is just one day later, unfortunately. You can see that there's increased purple lesions on his leg, and this is the skin necrosing down to the layer of that fascia. And he needed to go to surgery. You can see again that outside ankle is getting much worse than the picture in the middle. And so we were able to finally get the patient to be amenable to surgery, make him realize, because the percentage of limb loss in this case is close to 60%. So that's a very high percentage of those who have this infection that actually lose their limb. And we're all about limb salvage. So here are the crazy pictures. So this is the first debridement that we did. and we were working alongside of the general surgery service. So this was a pretty unfortunate procedure, because as we were debriding that skin away, we could see that there was more dead tissue beyond where we were, and you can see those little black speckles, and that's all further infection, and it's significantly deep. So now we're getting down to bone, we're getting down to muscle, and the hopes of this leg surviving is not good. So this is extending into the patient's knee, and we're getting more proximal or further up the leg because of how aggressive this infection is. This is him and the second procedure, and unfortunately this patient ended up with a amputation, a proximal amputation, which is so sad and unfortunate. And it's something that you deal with as a resident. You try to educate the patient as much as possible, and you know that you have the skills to surgically do something for them, but at the end of the day, there's a in between of where you can get to. So that is, an infection case. This is a cool case. Felt really bad for the guy who was a young 26-year-old patient who was a truck driver, or sorry, a garbage truck, and he specifically was on the back of a garbage truck when his foot unfortunately slipped and got caught in the mechanics. And this is called a degloving injury. And I was a first year, along with my co-resident, and unfortunately the patient ended up in the trauma unit, and myself and my co-resident were called down to the bay for this trauma. And I'll be honest, I was as you can imagine, as a first year, not seeing a whole lot. I knew that this was, not going to end well, but I also knew that there are things that you need to check when you see a trauma that of this significance. So we already know it's considered an open fracture. The front of the foot is fractured on the back of the foot, and the skin is sloughed off. So the first thing you need to think of in this case is blood flow. Does the patient have enough blood flow to survive the foot and the heel that has now been degloved? So immediately asked for what's called a Doppler, and this Doppler is able to see if the patient has pulses. Now, luckily, this patient did have both pulses that go into the foot, and we assessed his pain, we assessed the injury, and we're like, okay, there's no way that this can be reduced in the trauma bay, but we do know that he's getting blood flow currently. So we need to get him to the operating room ASAP. So on the far right, you can see an x-ray, and this x-ray was completed after we took him to the OR and reduced the front of his foot on the back of his foot. So I don't know, my pointer doesn't show up, but where those wires are crossing, that's called the Liz Frank joint, and that's where the fracture was. So we were able to relocate and then pin it with these pins just to at least get his foot into realignment. And what that does then is allowed to take stress off of the vasculature going into the foot. And then we had to deal with the flap. Now, unfortunately, I don't have the imaging from later down the road, but this patient had a long journey. So the flap that was of the heel ended up dying because the force from the trauma was too much for that skin, as well as the veins, which are located more in your skin, were all severed. So blood was able to get down there, but blood wasn't able to get back out. So then this heel became congested, so a lot of just stagnant blood, which will cause the flap to die. So the patient had to go under grafting, and we do grafting too, whether it be taking a sample of skin from the leg and transposing it and relocating it to the foot, or we also use biological grafting, those that maybe come from pig, we can put on the skin to help the wound heal. So these are just two inpatient cases. We'll now go to the outpatient cases, and I think we're doing okay here on time. But outpatient cases, I have 3 of them. We'll blast through these pretty quickly here, but the first one's really cool. I actually wrote a poster up on this, but a neuropathic patient had a bone tumor in their foot, and then it got infected because the patient, again, refused surgery. So eventually was able to get the patient to go to surgery. Then we have your typical bunion that you'll see a lot as a podiatrist. It's one of the most common ailments in the population that comes through your door. And then a high energy ankle fracture. So the reason that this is an outpatient case, ankle fractures can do well if you rest them for a week or 2 and try to get swelling down in order for the procedure to have better outcomes for their flap, for their surgical flap. So this is the patient with the bone tumor. You can see there's a callus on the bottom of the patient's foot. It's a very odd place. It's very built up. There's even a little hole in the middle of there. You can see the x-ray in the bottom left, and you can see that there's this excess bone that shouldn't be there. And this patient had documented, he's in his 40s, but when he was in his 20s, he went down to a local hospital and it was confirmed that he had this bone tumor, but nothing was wrong with it at the time. So it was decided not to do anything. But as the patient became sick and had neuropathy, had no sensation, the patient developed this wound, and eventually this bone became infected. We as a podiatrist, as a podiatry resident, you really need to know how to read imaging, because this is an MRI. This is very difficult to read since it's both a bone infection and a bone tumor. So as a resident, you do a radiology rotation and you work with musculoskeletal radiologists to learn how to read these, and you really build your skills up. So I feel comfortable reading this MRI and seeing that there is a bone tumor there, and this radio, or my apologies, the intensity that you see in box D, that is all inflammation. And specifically, you can see there's a low intensity rim around that high intensity, and that's where your bone infection is hiding within the bone tumor. So what we had to do is, unfortunately, we had to remove the bone tumor and the infection. We can't leave infection in there. We had to get it out. And unfortunately, the patient walked on his foot and still had a large hole in the bottom of the foot, but with persistence and finally closure, after 8 months, we were able to get the patient back to a normal ambulating foot. And you as a podiatrist, as a podiatry resident, you have to really appreciate the mechanics of the foot, because you can imagine if you're missing the middle 2 toes, there's going to be increased pressure to specific areas in the front of your foot. So we were able to fit him with a custom orthotic and a custom shoe so that he was able to walk properly again without creating any new lesions to his foot. So a really interesting case. So this is your typical bunion. You guys, if you do get into podiatry, you're going to see this a lot. And there's a million different ways to do a bunion right now, but during my residency, in evidence-based medicine, I've come to a conclusion of how bunions should be treated. And so we do our workup as a resident. You need to know your angles. That determines possibly what sort of procedure that you're doing. In this case, we're always going back to where we believe the true etiology or the true source of where the bunion occurs, which is not where the bump is. It's much more proximal to that or behind that. And you can see with these x-rays, you can see where we did surgery. So we believe in going back to the joint behind it and then prepping that joint, derotating the deformity, and then fixing that bone in the position so that it's straight as an arrow. And you can appreciate the pre-op, which is on the upper right hand, and the post-op, which is the upper left. And then the clinical picture. So this was, the pre-op clinical picture. And then you can see that the patient had the correction performed and that the toe is now straight and the patient is very happy. With this specific construct, we were able to walk the patient right away too. So as a resident, this is very rewarding because again, so this was towards the end of my second into third year, and you build a relationship with attendings to the point that they are allowing you to do more of the procedure. So I was able to do this skin to skin, as we say, and be able to work with a newer jig to correct this bunion, and it was very satisfying. It was great to hear that the patient was satisfied and to follow up with this case. But you get to learn as a resident what you really prefer when you get out. So real quick, this is one of our bread and butter traumas is an ankle fracture. A lot of fun to work with. You know, you're trying to make a worse situation better. It's not like this patient decided they wanted an ankle fracture and you're trying to give them the best outcome possible. Obviously, you always are, but it's kind of like a jigsaw puzzle. So the ankle has already been compromised. The patient needs to know that they're going to have arthritis at the end of this. And you learn this throughout residency after treating so many patients that this is a possibility. And again, education, education, education. I can't stress that enough. And that's why it's so fun to be a specialist. It really is. You learn the intricacies of the foot and ankle, and you're able to really drive home points with patients because you are the specialist of the foot and ankle. As you know, maybe if you listen to the other webinar series, we spend many years in this. So 4 years of podiatry school, a 3-year residency, and then if you decide to do fellowship. So that's a lot of time spending specifically on just the foot and ankle. So this patient did well. We ended up using internal fixation, as we say, so a bunch of plates and screws. And you have to know which order to fix all these fractures in, and you have to be able to read the x-rays to see where the fractures are so you know where to fix them. So on the inside of the ankle, you can see there's 2 screws, and on the outside of the ankle, there's a plate with a couple screws trying to stabilize that fibular fracture. So the outside of your ankle is your fibula, and then you have the tibia, and then underneath your ankle is your talus. So we have to make sure that that joint line is perfectly congruent, that it's even throughout that whole space. So that's what we're looking for when we're doing those. And that's the imaging from the scope. So real quick, it's important to appreciate the social life of a podiatry resident. Our work life is one thing. So this is my work life. There's hard times, and then there's also fun times. So we have a softball league at the hospital. We were the champs when I was a second year. Getting relationships with your attendings is always so rewarding, to be able to go to football games with them, to be able to really enjoy doing surgery with them. Upper right hand corner is my director, and he's like our dad. He is the glue to the ship. He drives the ship and has been a great leader for us. And just staying in contact with your past residents that you were working with. You got to have a lot of fun during this because it is a lot of hard work, but it's not just all work. We do have some fun. And then your home life. Podiatry has been great for me. I've been able to, see my family a lot. First year was rough, but you get through it, and you still get to go on vacation. You still get to play with your puppy. And my wife and I were expecting here in the late summer, so you're still able to really have a good family life if you so choose. As far as I love so that's Captain. That's our 2-year-old miniature golden doodle. He's been a breath of fresh air over these past 2 years. But so that's a lot what I have for you. Just some things to hit on or take home points. We work with other services. We're in parallel with them. We're all trying to do the same thing. especially with diabetic limb salvage when we're working with the vascular surgeons and the infectious disease doctors and medicine doctors. And I think, that's pretty much it for the talk. And if you guys are on Instagram, you can follow me at Dr._Jeffery Z. And there's my information if you want to directly contact me. I'm always open to helping students out in any capacity possible.
Dr. Zimmerman, you have shared a ton of great info, and how awesome to see some of those cases. We do have a couple questions for you. So
Awesome.
The first one I wanted to ask, how many, and before I get started in these, to you guys listening at home, you can submit your questions through the question box on the GoToWebinar toolbar, and they come straight to me, and I'll be asking Dr. Zimmerman. So don't be afraid to ask away.
Yeah, please do.
The first question we have, how many surgeries do you typically perform a week as a resident?
Okay, that's a great question. So in our residency, that was one thing that I was looking for coming into residency. I wanted to make sure that I was getting a high volume of surgery, so objectively it was good to have high numbers, but subjectively you also wanted to make sure that you were getting the knife and doing all those sorts of things to get firsthand experience. So having said that, at my residency, I averaged anywhere from 7 to 12 procedures per week. We generally have 3 residents on service, which when you're on service, that means that you're directly doing podiatry. And we have anywhere from 20 to 40 cases on per week. So on an average week, I would say 10 is a good number. And this varies too. At this point in my career, I've tripled my, when you get into residency, you have to have a certain number of procedures in order to graduate. And luckily at Reading, we triple our numbers, usually by mid 3rd year, sometimes beginning of 3rd year. And now I've been able to shift some of those cases to my junior residents, and then I scrub in with them and help teach in that capacity. But so anywhere from 1st to 2nd year, that number can always vary.
Good to know. I think this is related to your necrotizing fasciitis case. Did you perform the below knee amputation, or did you have to hand it off to another specialty?
So we were working with general surgery, and they do their own proximal amputations. So legally, we do not perform below knee amputations as a podiatrist in the state of Pennsylvania. Now, I have heard of podiatrists in the Western states that have more liberal privileges, but as a podiatrist resident, you do work with vascular surgeons either 1 month or 2 months during your program. And honestly, if you like, I'm very close with my vascular surgeons at the hospital, and if we have a common patient that had an infection and then went on to a below knee amputation, they generally ask us to come in and scrub with them, and they end up allowing us to do the procedure. So this particular one we did not, but I have done below knee amputations as a resident.
Awesome. What, I believe you mentioned you went to Temple. So what made you pick Temple as your school?
Good. So there's 9 podiatry schools. I ended up applying to 6 of them, and I began my journey going to Des Moines. Love Des Moines. Unfortunately, it was during the winter months. I was a February interviewer, so it was a little rough out there, but then went to Chicago again, was very comfortable there, and then I finally ended with Temple. And I felt at home when I was at Temple. It was certainly a feeling thing, but I didn't walk away from that interview saying I want to go there. I am a little bit more deliberate, so I do the typical pros cons list, and talking with family, friends, of course at that time, my girlfriend and who I was planning on proposing to, that was multifactorial. So I knew I wanted to practice in Pennsylvania. I knew I wanted to set my roots there. So it financially and educationally made sense. What was beautiful about Temple was their huge clinic. New York and Temple have great clinics, and I have no idea how many patients I saw when I was at Temple. It's too many to even count, and it was an extensive amount of pathologies. And just like clinical education, the academic education I felt was there too. I was really happy. I would do it in a heartbeat again. I would go to Temple. I love the city of Philly. I love the school, and made really good lifelong connections with some of my attendings there.
How lucky. That's awesome. Everybody should
Yeah,
hope for that.
yeah.
Can
I'm
you
very thankful.
can you tell us a little bit about the average number of hours you work per week as a resident?
So that's a little bit of a gray, well, it's not a gray area, but it's
There's a lot
so
of variables.
yeah, there's a lot of variables. So certainly as a first year, it's more time consuming. There's a lot more time that's involved. At our residency, we're built on a tier system for calls. So as a first year, you have about 120 days of call out of the year. So this is your nights and weekends. This does not include day call, which is 7 to 4. And as a second year, you then have 20, or sorry, I believe it is 40 days of call, and then you only have about 12 when you're a first year or a third year. My apologies. Again, does not include day call. So when I was a first year, off the books, I was probably putting close to 90 to 95 hours in when I was on service. But when I was off service, it was less than that. However, you're at our program, you're still on call. My second year, it was closer to 80 to 60, and now these days, I'm probably pushing like a 50 to 55 hour work week. I tend to put more work on myself because I I do what I can to try to better our program and to do a little bit of work outside of the residency, but it's all worth it in the end. I you definitely want to love what you're doing, or at least have a passion for it, because it when you get into this medicine, it's a lifelong medicine.
That's helpful, I can imagine. Can you touch a little bit? So we got a question here about traveling to different cities, and I'm assuming as a fourth year podiatry student, so I'm assuming this is related to interviewing with different residency programs. Can you touch a little bit about CRIP and explain sort of how that works and maybe how you came to select your residency program?
Yeah, absolutely. So at Temple at the time, we were only allowed 5 externship months. Now it's up to 6, and some other schools offer 7 or 8. So Reading was one of them. I actually had to cancel an externship in order to get into Reading because it was their first year doing an externship. So that was a little hard for me because I do not like breaking promises with a program or with anyone. But I knew that's how much I knew I wanted to do Reading. But CRIPS was very good. It's a nice centralized program. Prior to you have created your CV, you created your application, and I only selected 6 interviews. Now at CRIPS, I had 4, and then I had 2 back home. I also interviewed at Temple and Penn, and they do their interviews on site at their program, so that was unique. But I felt very comfortable at the CRIPS program. I stayed offsite. I did not stay in the hotel where they have the centralized program as to just disconnect from the daily interviews. But at that moment, prior to getting there, I knew what was my number one, and I'd be transparent and I don't give false promises. So I held my cards tight, but I one thing that I can take away from that is do you try not to get bogged down with what other people are saying and things like that, because it can really mess you up mentally when you're trying to think about ranking. So after you complete your interviews, you then have to rank. And I ranked the programs that if anything were to happen, I would only rank those that I truly would only want to go to. And then I would just deal with having to scramble. Um, and then the on-site interviews went pretty smooth too, but it is a stressful time of your life, um, but it definitely makes you stronger after you get done with it.
Absolutely, I can imagine. It's definitely a stimulating environment, I can
Yeah, that's a great
assume.
way of saying it.
And so for those of you guys that may be listening, what CRIP is, and correct me if I'm wrong, I believe it stands for the centralized residency interview process. So essentially, a number of residency programs from across the country travel to Texas. I believe it's in Frisco, and fourth year students travel there so they can interview with multiple programs at a time without having to sort of travel all across the country. And then that's where they, meet folks from different programs and interview and all that fun stuff. And that takes place in January, if I'm not mistaken. So it's
Yep,
always a good
that's
time.
correct. Yeah, that's actually a good point. Like, out to our audience, this is a very unique situation as compared to our DO and MD colleagues that are set up very differently. We're fortunate enough, and that's one beauty about podiatry. We are, in perspective, a small community
Hmm.
of doctors. So we have the fortunate ability to have this centralized program, and it truly does save a lot of money. Because as you can imagine, if you're applying to some of my classmates, they ended up applying to upwards of 18 interviews. So imagine trying to do 18 interviews at different locations if you were in a different program. So this is definitely a beautiful thing about podiatry.
With that being said, how do you feel your education at Temple helped prepare? Did you feel prepared for residency when you started?
Yes. Yeah. Um, when I started school, I had the mindset, I was very fortunate that I felt like I found my calling. And um, every day when I'd be studying or something like that, if it was tough, I just remind myself I'm studying for my future patients. I'm studying for myself, but I'm studying for those that I'm going to be treating. And if you have that mindset, that definitely gets you through a lot. It makes you really push hard to be able to study as much as you possibly can so that you have the best knowledge for your patient. And that's a mindset that I went through schooling. And now I'll say that academically, I felt prepared for residency, and you definitely have to have a good work ethic. You're never truly prepared for that first week, because you definitely get to push yourself to exhaustion. But I felt like Temple prepared me for that situation. And the schooling is definitely, it's a location, it's a place, they provide you knowledge, but you yourself has to be prepared to take that knowledge in and to retain it as much as possible. And because I think, it's hard to say this, but I feel like if I would have went to any school, I think I hope to have had the same outcomes at each school. That their
Yes,
standards, that they're all doing
absolutely.
similar things. So if you want to get into medicine, definitely make sure that that's what you want to do, so that you take it very seriously and you enjoy yourself. But it's a very large investment. You're investing in yourself. So you definitely want to be sure of that.
So as we're running out of time here, I will end on this note with this last final question. Dr. Zimmerman, what is the next step for you in your career, and do you have any advice for future podiatry students?
Yeah, so I was fortunate enough to land a job with my director at the program that I'm at. When I was looking, I knew I wanted to be close to a residency, and geographically, I'm originally from this general area. So I will be moving on to a larger for the area. It's a larger podiatry group practice, so it's not a multi-specialty, but it is a group practice that I'll be working out of 2 offices, and then I will be doing surgery on a weekly basis, either at the hospital or at the surgery center. I'll be involved in the residency with teaching, and that is truly my passion, is to be able to teach as well. But as far as advice for podiatry students, you don't have to go to a program like I did based off of geographical area if you're planning on practicing. That was not my sole purpose of going to Reading. I was just very fortunate to get a program that I felt like I would be above average with my training, but also be able to grow roots here and be able to practice here afterwards. So you definitely want to find a program that fits you. I always tell students that rotate through, when you go to visit programs, always objectively define them for you and then subjectively define them. So for me, I wrote down how many cases each resident was doing per week, per year, and then averaged them if I had multiple residents, to be able to see those objective numbers, and then try to objectively define how much they were doing in that surgery and what their skill level was. And then subjectively, I was like, do I see myself fitting in with this atmosphere? Every program has a different atmosphere. And I was fortunate enough that I fit in at Reading with attendings and residents. So that's my greatest advice to the students when they're looking at externships and looking at residencies, is to definitely think in that mindset of objectively, what are my goals? What do I want to get out of this program? And then subjectively, will I see myself here for 3 years and be happy?
What great feedback, and seriously, something that can be applied to all the various steps throughout your podiatry career for sure. I want to thank everyone for their great questions this afternoon and for taking the time to join us. And a super big thank you to Dr. Zimmerman for joining us as well. Guys, I know we weren't able to get to all of your questions, but we have Captain the Golden Doodle and Dr. Zimmerman's contact information on the screen. Feel free to send him a note, reach out to him on Instagram, whatever works best for you guys. I'm sure he'd be happy to entertain your questions.
Absolutely.
Thank you for that. We're working to schedule our next Step into Podiatry webinar now, so be sure to follow us on Instagram, official_APMA, to stay up to date on all of our upcoming student activities. And until then, Dr. Zimmerman, thank you. And I hope everyone stays safe and healthy, and we look forward to seeing you all next time.
Thank you so much, Tiffany. I really appreciate it again for having me on this, and good luck to all those students out there.
Anytime. Thanks, everyone. Have a great afternoon.
You too.